Welcome back to the deep dive. When we think about a patient recovering from major surgery, it's it's very easy to focus on what happened in the operating room,
Mm-hmm.
the technical skill,
Mm-hmm.
but the real battle, the one that determines the outcome, is often fought afterwards. It's about the body's ability to heal itself, and that takes fuel.
A massive amount of fuel.
Yep.
And the right kind of fuel managed in the right way.
Exactly. We're talking about the absolute fundamentals of life support, not just, a diet plan.
Mm.
So today, we're doing a serious deep dive into the bedrock of surgical care.
We are.
It's Chapter 25, the 28th edition of Baily and Love's Essential Clinical Surgery. Nutrition and fluid therapy.
A huge topic. And a critical one.
It really is. And our mission today, especially for those of you deep in clinical training, is very specific. We're not just going to read the textbook to you. That's boring.
Right.
We want to be your guides through this. We're going to interpret this dense chapter, pull out the really high-yield concepts, and hopefully create some sticky metaphors and anchors to make it all make sense. A ready reckoner, a revision map.
We still absolutely encourage you to read the full chapter, of course. The nuance is in the text.
Oh, absolutely. But this is the framework. This is how you master it.
Mm-hmm.
So let's just get right into it and establish our core principle. The entire mission here, the thing that underpins everything we're about to discuss, is this.
Mm-hmm.
Optimal nutritional status before and after surgery is probably the single most powerful tool we have for cutting down complications and improving outcomes. It's that simple.
It is. If a patient is already running on empty, if they're malnourished coming in, the biological price of recovery can be too high.
And that's the perfect place to start, because before we can even talk about, how to feed someone, we have to understand the size of the problem. We have to be able to tell the difference between two totally different states.
Right. One is simple starvation, the slow, kind of planned, adaptive process.
And the other?
The other is the chaos, the destructive metabolic furnace blast of trauma, sepsis, or major surgery. They are not the same thing. Not at all.
So let's start with that first model. Simple starvation. A patient is fasting for a routine procedure, maybe for 24 hours. How does the body handle that planned drawdown of energy?
Well, it's actually remarkably efficient. The body's top priority is keeping blood glucose stable.
For the brain, right?
For the brain, for red blood cells, the renal medulla. These are tissues that absolutely need glucose to function. So in that first phase, maybe up to 24, even 40 hours, the energy comes from glycogenolysis.
That's the quick access stuff.
Exactly. It's the glycogen stored in the liver and to some extent in your muscles. The body breaks it down, converts it to glucose. It's a fast system, but the tank is pretty small. Once your insulin levels drop and glucagon goes up, you burn through those reserves quite quickly.
Okay, so after, say, 48 hours, those glycogen stores are gone. The system has to make a major pivot. This is when things get more complex and more destructive, I guess.
It is. The body switches into prolonged fasting mode. And this is really driven by two things happening at once. First, you get gluconeogenesis.
Creating new glucose.
Creating new glucose from scratch, from non-carbohydrate sources. And where do those sources come from? Primarily amino acids like alanine and glutamine, which are stripped from skeletal muscle.
So the body is literally eating its own muscle just to keep the brain fed.
It is, and it's not a small amount. We're talking about a protein loss of up to 75 grams a day in an average adult just to meet that baseline glucose demand. But, and this is the clever bit, the body has a backup plan.
Okay.
At the same time, it kicks off lipolysis, breaking down fat stores. And this does two things. The glycerol part of the fat gets used for more gluconeogenesis, but the fatty acids get turned into something else.
Ketone bodies.
Ketone bodies, exactly.
Yeah.
Acetoacetate and beta-hydroxybutyrate. And this is the critical adaptation.
This is the trick that saves muscle.
It's the whole game. Most tissues, and very importantly the brain, can learn to use ketones for fuel. By switching to ketones, the brain's demand for glucose plummets. And if you don't need as much glucose, you don't need to break down as much muscle. It's a brilliant muscle-preserving strategy.
And the whole system slows down to conserve energy too, right?
Right. The whole metabolic rate drops. Your resting energy expenditure can go from, say, 25-30 kilocalories per day down to maybe 15-20. Part of that is driven by a reduced conversion of thyroid hormone T4 to the more active T3. So starvation, in this sense, it's an efficient, managed energy crisis.
Okay, so that model adaptive, efficient muscle sparing is the complete opposite of what we see after major surgery. So let's turn up the heat. We're going from the planned drawdown to that emergency furnace blast of trauma or sepsis. What's the physiological trigger for this hypermetabolic state?
It's an immediate, massive neuroendocrine storm. It's not like starvation where hormones are pretty low. Here you get a huge rapid surge of catecholamines, epinephrine, norepinephrine, plus cortisol, glucagon, growth hormone. It's a survival switch designed to flood the body with fuel no matter the cost.
And the first consequence is that the energy equation flips completely. Instead of needs going down, they shoot up.
Precisely. Energy requirements can increase dramatically, sometimes up to 40 kilocalories per day, or even more in severe burns. And this is happening while the body is just hemorrhaging protein. You get this massive net tissue breakdown, a huge negative nitrogen balance. That is the definition of a hypermetabolic state.
But the thing that makes it so uniquely destructive,
Mm.
the thing that really separates it from starvation, is that the body loses its ability to switch fuels efficiently.
That's the absolute heart of the problem. In this overwhelming hormonal storm, that beautiful adaptive muscle-saving mechanism is just gone. The production of ketone bodies, and even more critically, the ability of tissues to use them, can be severely impaired.
So the body can't pivot to using fat to spare muscle.
Right. It's stuck in one gear. The stress hormones are screaming, make glucose, make glucose. And because it can't efficiently use the ketones from fat, it's forced to rely on breaking down muscle protein as its main fuel source. It just accelerates lean muscle loss at a terrifying rate.
So you've got this accelerated protein breakdown, and then on top of all that, you have this other major problem that surgery causes, insulin resistance.
It's a huge component of the metabolic chaos.
And it seems to happen in almost every surgical patient. Why is that?
Well, surgery is tissue damage.
Yeah.
And tissue damage creates inflammation and stress. You combine the pain, the immobility, maybe some hypoxia, and this flood of inflammatory cytokines like IL-6, and the result is profound insulin resistance in the muscles and other tissues. And this leads to the worst possible outcome: hyperglycemia. You've got the liver churning out massive amounts of glucose because of the stress hormones, but at the same time, the muscles are refusing to take it up. The GLUT4 transporter protein just isn't working properly.
It's a total metabolic disaster. High fuel demand, the body is dismantling itself to make glucose, but the tissues can't even use the glucose that's already there. So the destructive cycle just gets worse and worse.
It is a profound state of metabolic chaos. And we know that if a patient comes in with pre-existing issues, type 2 diabetes, obesity, cancer, cachexia, that insulin resistance is worse, it lasts longer, and it directly correlates with higher rates of infection and mortality.
Which means we have to actively do something to stop it.
Yeah.
We can't just let it happen. The chapter points to some really proactive strategies, the kind of things we see in enhanced recovery pathways.
Exactly. The goal is to blunt that stress response. Things like preoperative high-carbohydrate drinks, which kind of paradoxically improve insulin sensitivity before the stress even hits.
Right.
And then, of course, using minimally invasive surgery when you can. Less tissue damage means a smaller inflammatory surge. And critically, getting patients moving early. Early mobilization is a powerful tool against insulin resistance.
Okay, this is the perfect spot for our first check-in. This is the core concept of this whole section. So for everyone listening, if a patient has been fasting for 72 hours, which energy source is the brain relying on most heavily? And then how does that shift if that patient develops a severe postoperative infection?
Just take a second to think about those two completely different states we just laid out. If you're thinking along the right lines, you realize that at 72 hours of simple fasting, the patient is in that adaptive muscle-sparing phase. The brain is relying heavily on ketone bodies from fat breakdown, but the second that severe infection hits,
The storm starts.
the storm starts. The hormonal surge disrupts ketone use. The system is forced back onto glucose, which has to be made from an accelerating breakdown of skeletal muscle. It's a switch from controlled adaptation to mandatory destructive catabolism. If that distinction isn't crystal clear, it's worth rewinding and listening to that part again.
It really is the most important principle. Which brings us to our key takeaway 1. Fasting is adaptive. Trauma is catabolic. The entire goal of nutritional support is to provide the right fuel to bridge that gap and preserve lean muscle mass when the body's under fire. All right, so moving from the deep physiology to what we actually do at the bedside. Nutritional assessment. You can't fix a deficit if you can't accurately measure it.
And this is where a quick case can really ground things. Imagine you've got a 55-year-old man. He's coming in for major bowel surgery for his really severe Crohn's disease. He's been sick for 6 months, chronic diarrhea, feels full really quickly. He just looks frail.
You know instinctively he's high risk.
You know it. But you need the data to prove it and to plan your intervention. And that's where we use the ABCD framework: anthropometry, biochemistry, clinical evaluation, and dietary assessment. The main point here is that you need the whole picture. One single number can be totally misleading.
Okay, let's start with A, anthropometry, the physical measurements.
Right. So this is the simple stuff, but it's crucial. Getting an accurate weight, calculating the percentage of weight he's lost over the last 3 to 6 months. We calculate his BMI, of course.
Yeah.
And then you can get more detailed with things like mid-upper arm circumference or triceps skin fold thickness to estimate lean mass and fat stores.
But, and this is a big but, these numbers can lie to you, can't they?
Yeah.
Especially in an acutely ill patient.
They can be incredibly unreliable, and this is our first big warning. That patient with Crohn's and diarrhea, he might actually come in with a normal or even a high weight. Why? Because he's so sick, he's retaining a massive amount of fluid, he's got edema. Any big rapid shift in fluid balance makes BMI and body weight almost useless for assessing nutritional status.
So we can't just trust the scales.
Yeah.
What are the absolute red flags then? The numbers that tell you this patient needs nutritional support right now.
The guidelines are very clear. You have to flag anyone with a BMI under 18.5 or who has lost more than 10% of their body weight unintentionally in the last 3 to 6 months. Or, the slightly lower threshold, a BMI under 20 plus unintentional weight loss of more than 5% in that same time frame. If they meet those criteria, their reserves are critically low. Their risk is high.
Got it. Okay, on to biochemistry. The blood work. We're looking at inflammatory markers like CRP, a full blood count.
Yeah.
But I want to focus on the most famous and probably the most misused nutritional marker of all, albumin.
Albumin, the great red herring of surgical nutrition.
Right. Why is it so unreliable in the acute setting?
Because it's a negative acute phase reactant. When a patient is sick, inflamed, septic, the liver just stops making as much albumin. And at the same time, their capillaries get leaky, so the albumin they do have just leaks out of the bloodstream.
So low albumin level isn't telling you about their long-term protein intake.
Not really. It's telling you they are acutely ill. It's a marker of inflammation and systemic illness, not necessarily chronic malnutrition. If you base your nutritional plan on the albumin level alone, you will be misled.
So if albumin is not the key, what labs are absolutely essential for planning support, especially when we're trying to avoid the most dangerous complications?
The labs you must have are the ones that predict refeeding syndrome. You need baseline electrolytes and renal function, obviously. You need a glycated HB to see if they have undiagnosed diabetes. But critically, you must have a baseline calcium, magnesium, and phosphate.
Phosphate is the big one.
Phosphate is mandatory. Knowing that baseline level is everything because a profound drop in phosphate is the hallmark of a refeeding crisis.
Okay, on to C, clinical evaluation. This is where a good history and physical really comes in.
This is where you figure out the why. You have to ask about symptoms. Are they constantly nauseous? Are they vomiting? Do they feel full after just a few bites? That's early satiety. Any trouble swallowing? And of course, you need to know about their bowel habits, any chronic diarrhea or constipation.
And you look for the big comorbidities.
Absolutely. A patient with cancer is in a hypermetabolic state already. Someone with inflammatory bowel disease can't absorb nutrients properly. Liver disease, dementia, Parkinson's. They all directly impact the ability to eat and absorb. And then you have the anatomical problem, short bowel syndrome, a high-output stoma, a fistula. These are things that physically bypass the absorptive surface.
And finally, D, dietary assessment. This is the practical bit of figuring out the gap between intake and requirement.
Right. You get a diet history, a food diary if you can, to estimate what they're actually consuming. And you compare that to their estimated requirement, which is roughly 25 to 35 kilokalogs of their ideal body weight.
And what's the trigger for intervention?
It's simple. You intervene if their intake is falling way short of their needs, or if you anticipate that the patient is going to be able to eat little or nothing for more than 5 straight days. This is key. It's about anticipation. If someone is scheduled for major abdominal surgery, you need a plan in place before they get into trouble.
And to standardize all of this, to make sure no one falls through the cracks, we have a tool, the MST tool. You call it the nutritional traffic light.
That's exactly what it is. It was developed by Baily, and its genius is its simplicity. It just combines those 3 key things we've talked about: BMI, percentage of weight loss, and this concept of the acute disease effect.
Which is that 5-day rule.
It is. If you think it's likely the patient won't eat for 5 or more days, you add a score of 2. And this gives you a clear risk level. 0 is low risk, 1 is medium risk, you observe, you rescreen. But a score of 2 or more is high risk. That means you treat immediately, you refer them to the nutrition support team, and you screen them weekly. It's a safety net.
A systematic way to make sure we intervene before that physiological debt becomes too great.
Exactly.
Okay, so once we've identified the problem, The next crisis, and it's often more immediate, is fluid and electrolyte balance.
Oh, absolutely. This can become life-threatening much faster than the caloric deficit. And the key here, as the chapter makes very clear, is obsessive monitoring of intake and output.
So let's go back to basics. The daily fluid balance for a healthy 70-kilo adult. What are we talking about?
About 30 milliliters per kilo per day. So that works out to roughly 2.2 liters. And you need to know where it comes from and where it goes.
Right.
So output is about 1.5 liters of urine, maybe 100 millioles in feces, and then about 900 millioles of insensible losses, the moisture you lose from your skin and just from breathing. That totals about 2.5 liters, and that's balanced by intake from drinks, food, and a little bit from metabolic processes.
And in a surgical patient, where can those insensible losses really spike?
They go up with anything that increases heat or bypasses the body's normal humidifying systems. So a fever, being very restless, a warm environment, and critically, a patient with a tracheostomy. That's a direct line for dry air into the lungs, so you lose a ton of moisture unless it's actively humidified.
And of course, pathological losses like diarrhea or NG tube output can be massive.
Huge. They can multiply the normal output exponentially.
Okay, so for maintenance fluids, there's also a basic electrolyte recipe. What's the daily requirement?
The baseline is about 0.9 to 1.2 millimole of sodium, about 1 millimole of potassium, and then smaller amounts, about 5 mmM of calcium and 1 mmM of magnesium per day. And you always have to remember the hierarchy of delivery.
Safest route first.
Always. Oral is best. Then tube feeding if the gut works. 5E is the last resort, only when you have to.
Which brings us to the minefield of intravenous fluid solutions. This is where we have to be really critical. The teaching point from the chapter seems to be this. No standard 5E fluid is a perfect replacement for plasma.
That is the single most important thing to remember. The choice of fluid has to be guided by what kind of fluid the patient has lost.
So let's compare them. We have to look at their chemical makeup against normal plasma. Sodium around 140, chloride around 100, and a pH of about 7.4.
Right, so let's start with the most common one, 0.9% saline. Normal saline. Look at the numbers. Its sodium is 154 and its chloride is 154.
That chloride is way off.
It's nearly 50% higher than the top end of normal plasma chloride, and its pH is very acidic, down around 4.5 to 7.0.
So what's the clinical danger of that huge chloride load?
The danger of giving too much saline too fast is creating a hyperchloremic acidosis. You're essentially overloading the body's ability to buffer acid by swamping it with chloride ions. It's a fantastic fluid for rapid volume resuscitation. It's cheap, it's available, but it is not a physiologic replacement fluid over the long term.
Okay, so then we have Hartmann's solution, or lactated ringers.
Hartmann's is a much more balanced, much more physiologic solution. Its sodium is 131, chloride is 111, much closer to plasma, and crucially, it contains lactate.
And the lactate acts as a buffer.
Exactly. The liver metabolizes the lactate into bicarbonate, which helps buffer acid. So your risk of causing an iatrogenic acidosis is much, much lower with Hartmann's compared to saline.
And the third major one is 5% dextrose.
Dextrose is just sugar in water. As soon as the body uses the glucose, you're left with free water. It's a hypotonic solution. You can't use it for volume resuscitation because it just leaves the bloodstream immediately. It's for replacing a free water deficit or giving IV drugs.
Now what about colloids? The plasma expanders like gelifusine or albumin.
Well, the idea is that the large molecules in them should hold fluid in the bloodstream for longer. But the evidence for their superiority over crystalloids is pretty controversial.
And they have risks?
They do. Certain starches have been linked to kidney failure, and they can interfere with clotting. Albumin really only has a role in very specific situations, like replacing fluid after draining large volume ascites in liver failure. It's not a general resuscitation fluid.
Which brings us to the need to match the fluid to the specific loss. We have to understand the electrolyte fingerprint of different gastrointestinal secretions.
This is so important. You have to know what you're replacing. So think about gastric juice from an NG tube. That fluid is really high in chloride, maybe 110 millimole, but actually quite low in sodium, around 50 millimole. Now compare that to fluid from lower down. Bile, pancreatic fluid, or ileostomy output. These are totally different. They're high in sodium, around 140, just like plasma, but they are incredibly rich in bicarbonate. Pancreatic fluid can have a bicarbonate concentration of 115 millimole. So if you just replace that loss with saline, you'd be replacing the volume and the sodium, but you'd be completely ignoring the massive bicarbonate loss, and the patient would develop a severe metabolic acidosis very quickly.
That makes perfect sense. And it sets up our next check-in question perfectly. So for everyone listening, patient has a high output NG tube, So they're losing stomach contents.
Mm.
They need a lot of IV fluid. Based on what we just discussed, which fluid, saline or Hartmann's, is more likely to cause a rapid electrolyte imbalance if you use too much of it, and why?
Think about the chloride. The chloride in the stomach and the chloride in the bag.
Right.
The answer is 0.9% saline. Even though gastric losses are high in chloride, saline's concentration of 154 is way higher. So if you're pouring in saline to replace these high-volume stomach losses, which are already causing a metabolic alkalosis, you're also adding this massive chloride load, which risks tipping them into a dangerous hyperchloremic acidosis. Hartmann's is just a more balanced, safer choice for that kind of replacement.
Okay, so our key takeaway too is fluid management requires a deep understanding of specific electrolyte losses. And saline, despite its name, is not a normal or physiologic fluid, and it carries a real risk of hyperchloremic acidosis.
Okay, so with fluid balance getting sorted, we need to deliver the actual fuel, the recovery recipe. We need to calculate the patient's specific energy needs.
We use formulas like the Harris-Benedict equation to estimate the basal metabolic rate, but there are some really important rules for sick surgical patients when we're setting these energy requirements.
Yeah, we have to remember that hypermetabolic state from the beginning. An unwell patient might need up to 120% of their predicted BMR. The general target for a stable patient, though, is about 20-30 kilocalocac of ideal body weight per day.
And you just said the key phrase there, ideal body weight.
It's the crucial rule, especially for obese patients. You must use their ideal body weight for all your calculations, not their actual weight.
Why is that so important?
Because if you use their actual weight, you will massively overestimate their needs and you'll end up overfeeding them. And overfeeding is dangerous. It increases carbon dioxide production, which makes weaning from a ventilator harder, and it increases the risk of metabolic problems and fluid retention. You have to start slow, especially if they're at risk of refeeding syndrome. No more than 10 kilocalc a day to start, and then build up over a week.
Okay, so let's break down the macronutrient breakdown, the fuel mix.
So carbohydrates should be about 45 to 65% of the total calories. The central nervous system needs about 2 grams of glucose per kilo per day, so that's non-negotiable.
And protein. This connects back to the catabolism we talked about.
It does. A healthy person needs about 0.15 grams of protein per kilo per day. The sick catabolic patient needs way more, up to 0.25 gkopil a day, or about 1.5 grams per kilo of ideal body weight. That high protein intake, maybe 20% of total energy, is specifically to try and counteract that massive muscle breakdown we saw in the hypermetabolic state. You're trying to push their nitrogen balance back towards zero.
And what's the role of fat in all this?
Fat gives you essential fatty acids, the ones the body can't make. And when you're giving parenteral nutrition, you always combine fat and glucose. You give a minimum of 200 grams of glucose a day with the fat. And this just helps optimize the metabolic pathways and, critically, reduces the fluid retention you'd get from a really high carb-only load.
And then there are the micronutrients, the cofactors for healing.
Vitamin C needs go up postoperatively for wound healing. You have to think about specific deficiencies. B12 is a big one after stomach surgery or in patients with alcohol dependence. And you have to watch out for malabsorption of the fat-soluble vitamins A, D, E, and K, especially with any pancreatic or biliary problems.
And trace elements like magnesium and zinc.
They're essential. They're not just optional extras. They are required to actually utilize the amino acids you're giving them and to help prevent the electrolyte chaos of refeeding syndrome.
Okay, let's shift to a very surgical topic.
Yeah.
The effects of intestinal resection. The gut is amazing at adapting, but it does have its limits.
It does. It can increase the length of its villi, add more transporters. It tries to compensate. If you resect the proximal jejunum, for example, the ileum and colon can often take over without much long-term trouble.
But the ileum is different. The terminal ileum is special.
The ileum is where the problems start. And here's our critical landmark. The 100-centimeter rule. The terminal ileum is the only place where bile salts and vitamin B12 are actively reabsorbed. If you lose 100 centimeters or more of it, you get bile salt malabsorption,
which leads to terrible diarrhea.
It leads to steatorrhea, a specific fatty diarrhea. The bile salts, which are needed to digest fat, can't get reabsorbed, so they spill into the colon and irritate it. You can treat this with drugs like cholestyramine that bind the bile salts, but if the resection is even longer, you have to seriously restrict fat in the diet.
And when the loss is really catastrophic, that's short bowel syndrome, SBS. So less than 200 centimeters of functional bowel left.
Right. And SBS has 2 phases. There's the acute stage for the first few weeks, which is just chaos. massive fluid losses, dehydration, gastric hypersecretion. Then comes the adaptation stage, which can take a year or two, where the remaining bowel tries to bulk up and improve its function. This is where you find out if a patient can ever come off parenteral nutrition.
And in the most severe cases, with less than 100 centimeters of bowel left, the fluid management becomes incredibly tricky.
It's life critical and it's completely counterintuitive. These patients can lose over 4 liters of fluid a day.
And this is where drinking the wrong thing can actually make you more dehydrated. Can you explain that?
Yeah, it's all about osmosis and sodium. If a patient with severe short bowel drinks plain water or any hypotonic fluid, anything with a sodium less than 90 millimole, that low sodium concentration in the gut lumen will actually pull sodium out of their blood and into the bowel.
And water follows sodium.
Water follows sodium. So by drinking plain water, they are literally pulling salt and water out of their own body, making the diarrhea worse and accelerating the dehydration. It's a disaster. So for these patients, hypotonic fluids must be strictly restricted to less than a liter a day. They can only drink specialized oral rehydration solutions that have a high glucose and salt content to force coabsorption.
That is an absolutely life-saving piece of information.
Okay.
Which gives us our key takeaway 3. Nutritional planning must use ideal body weight and start slow. And surgical loss of the ileum, especially more than 100 centimeters, completely changes nutrient and fluid handling, requiring careful salt management and restriction of hypotonic fluids to prevent that paradoxical dehydration.
Okay, so we know what they need. Now, how do we deliver it? The delivery systems. Let's set up a scenario. Our Crohn's patient from earlier, he's had his surgery, but on day 3, his bowel just shuts down. He develops an ileus, his nutritional state is terrible, the gut isn't working. What now? Well, that scenario perfectly illustrates why we need 2 parallel systems. We always prioritize A, enteral nutrition, EN, feeding the gut whenever we possibly can.
Let's anchor those benefits of EN. Why is it so much better?
It's trophic. It keeps the gut healthy. Feeding the gut preserves the mucosal barrier, prevents atrophy, and maintains gut immunity. The data is very clear. EN is linked to lower infection rates, less severe sepsis, and better wound healing compared to feeding through a vein. The gut needs to be used to stay functional.
And the delivery methods range from simple oral drinks all the way to feeding tubes.
Right. Oral supplements, NG tubes, NJ tubes, or longer-term options like gastrostomies, PEGs, and jejunostomies.
Let's talk about the mechanics of placing those tubes. There's a big difference between aiming for the stomach and aiming for the jejunum.
A huge difference. A nasogastric tube or a gastrostomy only works if the stomach is emptying properly. In critically ill patients, or post-op, the stomach often doesn't empty well, so you need a post-pyloric tube, a nasogenital or jejunostomy tube, to bypass the stomach completely.
And for placing an NG tube on the ward, verification is everything. We can check the pH of the aspirate. If it's less than 5, you're probably in the stomach. So why is a chest x-ray still so often mandatory before starting a feed?
That's a critical safety question. The reason is that, despite the pH test, it is still possible, especially in a confused or very ill patient, for that tube to have gone down the wrong way into the lung.
A disaster.
A catastrophe. And if the patient is on antacids, their gastric pH might be falsely high anyway. The X-ray is the only thing that gives you absolute anatomical certainty that the tip is below the diaphragm, past the carina, and safely in the GI tract. It prevents the disaster of feeding into the lungs.
And that's why NJ tubes always need to be placed with an endoscope or X-ray guidance, right? You can't just do that blind at the bedside.
Exactly. You can't guarantee its position past the stomach without that visualization.
And for long-term feeding, we often use a PEG tube. How does the technique of placing a PEG specifically prevent peritonitis, that leakage, into the abdomen?
It's a really clever technique. The endoscopist uses the scope to shine a light through the stomach and abdominal wall. When they place the tube, it has an internal bumper or a cuff that is pulled up snug, physically holding the stomach wall right up against the inside of the abdominal wall. This creates a tight seal and allows a safe tract to form, which dramatically reduces the risk of leakage.
But even with EN being the preferred route, it's not without problems. What are the common complications of EN?
Tube problems are the most common. They get blocked or they get displaced. And you should never, ever try to unblock one with a guide wire. You'll perforate the tube or the patient. Just use water flushes.
And GI problems.
Diarrhea is very common, happens in over 30% of patients. And aspiration is the ever-present fear. If you're aspirating large volumes from the stomach tube, it means they're not tolerating the feed, and you have to slow down or stop to prevent aspiration.
And when is EN just not an option at all? When do we have to switch to the IV route?
If there's a complete mechanical obstruction, a profound, long-lasting paralytic ileus, or just not enough functional bowel left, like in our severe short bowel patient, in those cases, the gut just doesn't work and you have to move on.
Which brings us to B, parenteral nutrition, PN or TPN, feeding through a vein.
This is the lifesaver when the gut has failed. The main indications are things like short bowel syndrome, a massive resection, or an intestinal fistula that needs time to heal. The composition is incredibly complex. It comes in a 3-liter bag with a precise mix of lipids, amino acids, glucose, electrolytes, vitamins, everything.
And the chemical nature of that fluid dictates how we have to give it.
It does. TPN solutions are extremely hyperosmolar. If you tried to infuse that into a small peripheral vein, you'd destroy it. It would cause severe thrombophlebitis. So TPN must be given into a high-flow central vein like the superior vena cava or the right atrium where it gets diluted instantly.
Which means the patient needs a central line.
They need specialized access, a PICC line, a standard central line, or for long-term use, a Hickman line or a port.
And just like with the NG tube, you have to verify the position.
Absolutely non-negotiable. You must get a chest x-ray after insertion to confirm the tip is in the right place, the lower third of the SVC or the atriocaval junction. A misplaced line is a huge risk for thrombosis or vessel damage.
And the monitoring is intense.
Daily weight, daily electrolytes. You have to be aggressive with replacing phosphate right from day one to prevent refeeding syndrome. It is a high-stakes, high-risk intervention.
That brings us to our key takeaway 4. Enteral is always physiologically better. But when the gut fails, TPN is life-saving, but it demands dedicated central access, mandatory X-ray confirmation, and a fanatical devotion to aseptic technique because the risks are so high. Okay, to wrap up, let's talk about the clinical dangers, the minefield. And we have to start with the single most dangerous yet totally preventable complication of nutritional support, refeeding syndrome. Our anchor here is simple. When you restart the metabolic engine too fast, the system crashes.
It's a catastrophe, and it only happens in severely malnourished patients when you start feeding them too quickly. During starvation, as we said, the body's metabolism is shut right down. Then you suddenly introduce this huge load of carbohydrate.
And the pancreas just goes into overdrive.
It releases a massive surge of insulin. And insulin is an anabolic hormone. It's a driving hormone. It forces glucose, potassium, magnesium, and most importantly, phosphate into the cells to fuel all this new synthesis. The body's already depleted. Stores of these electrolytes just can't handle that massive shift from the blood into the cells.
And the most critical and deadly deficiency is the phosphate.
Profound hypophosphatemia. That's the hallmark. The phosphate gets consumed immediately to phosphorylate the glucose. That, along with low potassium, low magnesium, and fluid retention, is what defines the syndrome.
And the clinical signs are just systemic collapse.
Total system failure, muscle weakness so severe they can't breathe, cardiac failure, fatal arrhythmias, confusion, seizures. It can be deadly.
Which is why screening for who is at risk is mandatory. The chapter gives very clear criteria.
They're essential to know. A patient is high risk if they meet either one severe criterion, like a BMI under 16, or more than 15% weight loss, or no food for more than 10 days, or if they meet 2 or more of the moderate criteria, like a BMI under 18.5, more than 10% weight loss, or a history of alcohol abuse.
So if you identify a patient in that high-risk group, what is the unbreakable rule for starting to feed them?
The rule is to go incredibly slowly. You must start at a maximum of 10 kilocalc day, not the usual 25 or 30. You hold that for 48 hours, then you gradually increase over the next week. And at the same time, you are aggressively monitoring and replacing electrolytes, phosphate, potassium, magnesium before the levels even drop. And you must give supplementary B vitamins, especially thiamine.
Okay, so besides refeeding, what are the other major complications we see specifically with parenteral nutrition?
Well, there are 3 types. First, insertion complications. You can cause a pneumothorax, especially with a subclavian line. That's one reason the post-insertion X-ray is so important. Second, and most catastrophically, are the line complications. Catheter-related sepsis is the biggest risk. It can affect up to 15% of patients. It demands perfect aseptic technique. If you even suspect sepsis, you have to get blood cultures from the line and from a peripheral vein, and if they're positive, the line has to come out.
Right.
And then there's thrombosis and blockages.
And finally, there are the more insidious long-term metabolic complications of TPN.
You're constantly fighting to control blood sugar. But the 2 big long-term worries are the liver and the bones. Liver dysfunction is very common. Over a quarter of patients on TPN will get abnormal LFTs. It starts as a fatty liver, but with long-term use, it can progress to fibrosis and even cirrhosis. We call it intestinal failure-associated liver disease, IFOLD. It's caused partly by overfeeding glucose, but also because the gut isn't being stimulated, which seems to have a direct negative effect on the liver.
The bones.
Metabolic bone disease, osteoporosis, osteomalacia. You have to be very careful with long-term supplementation of calcium, phosphate, and vitamin D to try and prevent it.
This detailed look at the dangers sets up our final question perfectly, bringing all these concepts together. So, a 68-year-old patient has esophageal cancer. His BMI is 17, and he's lost 12% of his weight in 6 months. After a major surgery, he started on enteral feeding at a rate of 25 kilocalories day on post-op day 1. Based on everything we've discussed, why is this nutritional plan dangerous, and what 2 biochemical parameters must be monitored like a hawk for the next 48 hours?
Think back to those risk criteria, the BMI, the weight loss.
He fits, doesn't he?
He is a walking textbook case for high risk of refeeding syndrome. He meets 2 of the moderate risk criteria, BMI under 18.5 and weight loss over 10%. That means starting feed at 25 kilocalories day is dangerously fast. It's 2.5 times the safe starting rate. He should be started at a maximum of 10 kilocalories day. And the 2 things you must be checking every few hours for the next 2 days are his phosphate and his potassium, because a sudden drop in those is the first sign of the impending crash.
That application of the rules just brings it all home.
It does.
We've completed our deep dive into nutrition and fluid therapy. We've gone from the difference between starvation and trauma to why albumin can be so misleading, to the chemical differences between IV fluids, the consequences of ileal loss, and finally the life-saving caution needed to prevent refeeding syndrome.
That's a lot to cover.
It is. So please use this as your revision roadmap, but remember that the full detail, the full nuance, is in the source text in Baily and Love, Chapter 25.
And we'll just leave you with this one last thought to chew on based on those long-term dangers we just discussed. We talked about the chronic risks of TPN, liver failure, bone disease. If this life-saving intravenous feeding has its own kind of ticking biological clock of complications, what does that tell us about the ultimate goal of all surgical nutritional support?
It tells us that the goal is never just to keep someone alive with a central line. The true goal of excellent surgical care is to do everything possible to protect and restore the function of the gut itself, because the highest form of success is a full transition away from artificial support back to a healthy working gut. That, more than anything, defines a win in surgical nutrition.
Well said.
Thank you for joining us for this deep dive. We'll see you next time.